Hello and welcome to another exciting lecture for developmental psychology. In this lecture, we will be talking about heredity. Then we will get to the prenatal environment, and we'll look at how prenatal development works. And finally, we will finish up with birth and a little bit of post-birth. So we are going to look at conception. We're going to look at the prenatal environmental stages. We're going to look at teratogens and the different types of teratogens and the effects some of those have. We're going to look at the perinatal environment, which would be the environment surrounding birth. And we will finish up with the neonatal environment, which is the environment immediately after birth. So let's start with conception. So conception, very easily defined as the union of the mature ovum and a sperm. So the mature egg from the female and a sperm from the male, when those two come together, you get conception. When you mix the two of these together, the genetic material of the cells unite to form what is referred to as a zygote. So when these two come together, at first it is a zygote. So let's incorporate evolution into our discussion here. So first off, gender is determined by the sperm. So the egg is always going to provide a X chromosome. The sperm is going to provide either an X or a Y. If it provides an X, the forming zygote is female, becomes female. If it provides a Y, the forming zygote becomes male. Now there are some exceptions to that. There are some genetic abnormalities where sometimes you'll get two X's or only one X, or sorry, two X's and a Y or only one X, or various different things there. But the gender is determined by the sperm. When we're talking about evolution though, we're not talking about necessarily the gender, but we'll talk about what happens if there's a gender imbalance in the population. So if there's a gender imbalance in the population, let's say something like war causes many of the males to die out, or something else relating to that, whether it's males or females that there's a deficit of. What ends up happening is women tend to have more offspring of the underrepresented gender simply because that's an evolutionary advantage. The gender that's underrepresented tends to get to be the chooser, and the others compete for them, which means the underrepresented gender has more mating opportunities, male or female. So women tend to have have more offspring of the underpopulated gender. How does this work though if the gender is determined by the sperm? First off, the way it works is first that the male sperm that would be a male, so the Y sperm, are actually faster. They don't live as long, but they're faster than the X sperm. So in the end, Y sperm are more likely to make it to the ovum and inseminate. And actually, and we'll talk about this in just a second, about out of every we're not just going to do 100, but the ratio is 120 males to females, 120 males to 100 females at conception. But why don't we have more males then, if that's the case? Well, one of the ways is through spontaneous abortion of the fetuses of the overpopulated gender. One thing we know is spontaneous abortions are more likely to occur with developing male fetuses. Spontaneous abortion is basically another way of saying miscarriage. It is the way of saying that the body spontaneously aborted the fetus. Quite often, spontaneous abortions occur due to genetic abnormalities. So something is wrong with the genetics of the developing fetus, and the mom's body basically gets rid of it as a result. Or the genetics, there's a mutation or something like that of the developing fetus, and it can't survive, and then the spontaneous abortion happens that way. In actuality, and we'll talk about this again later, but in actuality, it's roughly 60% of conceptions result in spontaneous abortions. Most of them occurring in the first 2 weeks, and the woman never knows she's pregnant. It happens often. Like I said, about 60% of conceptions result in spontaneous abortions, almost always due to genetic abnormalities. Okay, well, I said that ratio at conception is about 120 males to 100 females. If there's an equal in the population, more males are likely to be aborted. Actually, when birth comes around, it's right around 105 to 100, 105 males to 100 females. But by age 20, it's closer to 100 to 100. Why might that be the case? Why? Okay, you've got at conception 120 males. Well, there's those spontaneous abortions. But even at birth, there's 105 males to every 100 females. Why is the gender ratio 20, or at age 20, 100 to 100? The simple answer is because boys are dumb. Boys have evolved behaviors that make them more likely to take risks. These risks can have great rewards, but they can also result in things like death. So the gender ratio, it's skewed at conception towards males, but by age 20, it's pretty balanced. So let's next look at the prenatal environment. The prenatal environment, another term for the prenatal environment, is the mother's womb. It is the protective environment for fetal development that the fetus develops in from conception until birth, and it is basically protects the developing fetus from a lot of different things that would be in the environment, especially while it's developing things like skin and lungs, so it can survive on its own. Big caveat though, some vulnerabilities are still present in the womb. So we'll get to that in just a few minutes when we talk about teratogens, but some vulnerabilities are still present. There are 3 stages during the prenatal period. So the prenatal period, again, is from conception till birth. You have first, which is the germinal period, and we will have slides for each of these, but the germinal period is very early on. Most women aren't even aware they're pregnant until the germinal period's over. Then we have the embryonic period. The embryonic period is going to be the period of time where the embryo develops before we get to what we classically define as the fetus. And then finally we've got the fetal period, which is where after that embryo period, where a lot of things like the organs are developing, where the developing fetus is growing, getting to the point of birth. Let's look at each of those. So first we've got the germinal period. So the germinal period, it lasts approximately 2 weeks. It is the period of time in which the zygote that is just formed starts rapidly dividing. So the zygote that's 1 cell becomes 2, becomes 4, becomes 8, 16, 32. It's just rapidly dividing during this time. And it's still floating around. It's still the egg that's floating around, and it floats to the uterine wall and implants itself into the blood vessels on the uterine wall. And during this time, it's also forming the blastocyst, which is basically the protective layer around it. So again, this is early on. You can't even really identify what it is, let alone know gender or anything like this. It's rapidly dividing. Even the picture you see there is probably after the germinal period, because it definitely doesn't have those features yet. It's more of just during the germinal period, it's a big blob. Then we get to the embryonic period, which lasts from the 3rd to the 8th week. So the embryonic period is where organogenesis occurs. That is, the organogenesis is the formation of all the major organs. And there's going to be, what we're going to talk about in just a little bit, there's going to be things like the critical periods of when these organs are developing the most. So you've got formation of every major organ: brain, spinal cord, heart, facial features, limbs, all of the major ones. The layers of the blastocyst start to differentiate into layers of things like down to the skin and things like that. And during this time you get sexual differentiation. So if you've got something that can test it, you can start to see by the end of this sexual differentiation. The last stage until birth is the fetal period. So it lasts from about the 9th week until birth. You'll see that the difference between the 8th and the 9th week is basically where a lot of the major organs have their major periods of development. That being said, cells are still proliferating, they're migrating, they're differentiating. You still have all these cells that are starting to develop into a actual developed human being, turning a jumble of cells into a human being. The organ systems continue to grow, they begin to function. In the age of viability, which is what is considered to be the period of time where the fetus can then survive outside the womb. It is about 23 weeks. I heard one example of someone surviving at 21 weeks, but that's the rare exception, and there might have been issues there that allowed that to happen. It's really what happens is in the 22nd week is when the skin is really finishing up developing, at least to the point where the baby can survive. If any time before that, so any time before the 23rd week, the baby that's born, their skin is just going to be like goo. It's going to be melting off from them. Like I said, it's possible, it's just really, really unlikely prior to 23rd week. And even at the 23rd week, you're looking at less than a 25% chance. The point is that the chance has risen enough that it's enough that life-saving measures are done. Before the 23rd week, typically life-saving measures are not done. I've actually heard from neonatal nurses about preemies who were born before the 23rd week and the parent insisted on life-saving measures, and just how they had nightmares for years afterwards about that baby and the way that baby was just not ready. So it's our age of viability when survival outside the womb is possible because the respiratory system and the skin have sufficiently developed is at about 23 weeks. During this time, during the fetal period, the fetus begins to recognize repeated familiar sounds. So it is during this time that the fetus starts learning. Let's talk about teratogens. So teratogens are not a fun thing. Teratogens are going to be anything that adversely affects fetal development. They're going to be typically things like drugs and medications that can make it to the fetus. They're going to be different diseases or even different environmental factors like pollution or radiation. These different things adversely affect fetal development. To talk about these, though, we have to talk about this term I mentioned a few minutes ago, and that's the critical period. The critical period is when the organ system, the specific organ system, is growing most rapidly. There is a different critical period for each organ system. So the heart has one, the eyes have one, even the ears have one. When we're talking about teratogens, what's also as important is dosage and duration. How large of a dose and how long have you been exposed? This actually should be something that you've been heard about and thought about over the last year and a half when we're talking about COVID, because your chances of getting COVID are based on your dosage and duration. How large of a dose did you get when you were around someone with COVID, and how long were you around them? The same thing is true for teratogens. How big of an effect it has on fetal development depends on the dosage, how much, and the duration, how long was the exposure. The longer the exposure, the larger the dosage, the more serious the damage is. The more chance there is of damage and the more serious it is. Also important is genetic makeup, because susceptibility to harm is actually influenced by genetics. It's influenced by the genetics of the mother and the baby. For a second, let's go back to dosage and duration. Let me give you an example here. So you always hear the old adage, you shouldn't drink while you're pregnant. Here's a couple things to consider there. First off, I'm not going to tell you to drink while you're pregnant, but dosage and duration are important. So if you have low amounts of alcohol, one drink is highly unlikely to affect fetal development. First off, it would have had to happen right at the correct time of the critical period, and second, it would have had to have been enough to affect it. There's actually some cultures that they recommend a glass of red wine every day for a pregnant woman. There's definitely some duration there, but the dosage is relatively low. So dosage and duration is important. It's one of those things like people say, well, women are worried. They're worried they got pregnant and they found out that they were 4 weeks pregnant, 6 weeks pregnant, something like that, and they say, oh, I was drinking a lot or doing drugs during that time. Well, we'll come back to that, how that critical period here and dosage and duration are important. And if you were doing those drugs before or drinking before the critical period, then it's unlikely to affect fetal development. And if your dosage and duration was low enough, it's unlikely to affect it. Final thing that's important is the environment. This is the quality of both the prenatal and the postnatal environment for the fetus. If the mother is in an environment where there's things like lots of lead paint, that's going to affect it. If she's in an environment where she's not getting enough nutrition, not getting those prenatal environments, that's going to affect how teratogens affect the body. And the same happens for after birth too. Let's look at those critical periods. So these critical periods are the periods in time in which these systems are growing the most rapidly. So when you look at it, there is some critical periods that start in the 3rd week. However, most of the critical periods go from about the 4th week here to about the 8th week here, when we're talking about when the major abnormalities can occur. These are when the organs are developing the most rapidly. And you look at that, and that's when you've got that period of time during the embryonic period before you get to the fetal period. I know the fetal period line's here, but even if we did the line here, you see that quite a few of them are cutting off before there. So it's during that time that major and minor abnormalities can occur. On the next slide, I'll talk about how we found out most of these. So, the first set of teratogens we're going to talk about is drugs, different drugs, chemicals that are taken in. First, the thalidomide. Thalidomide I talk about first because thalidomide is where we discovered a lot of the critical periods. That is because thalidomide causes a lot of different birth defects, and it causes birth defects depending on when it was taken. So what was found is that they found that this woman took the thalidomide when she was 5 weeks pregnant, and it resulted in a abnormality of the central nervous system or the heart or the arms, the eyes, the legs. Then it was at 5 weeks. That means those were developing the most during that time. There was no abnormalities to teeth, palate, the genitals, things like that. So that means those weren't developing at those times. And we're not talking about just one woman. We're talking about thousands of women tens of thousands of women who had taken this drug at different times when they were pregnant, and then they saw what abnormalities occurred and basically could then correlate them. Why were tens of thousands of women taking thalidomide while they were pregnant? Because thalidomide was prescribed in the 60s. Believe it was the 50s and 60s. It was a short period of time, but it was prescribed for morning sickness. We will talk about morning sickness later in a few slides, but for now we'll just say that it was prescribed for morning sickness. It was prescribed directly to women, and it ended up causing these birth defects. Another one is tobacco. Tobacco results in low birth weight, cleft palate like you see here, premature birth, sudden infant death syndrome, SIDS. Alcohol results in fetal alcohol syndrome, where you see with the girl here how on the upper lip specifically, how it's smooth. You get that smoothness on the upper lip. You see how the girl on the left, she has ridges on her upper lip, and the girl on the right, it's smooth on the upper lip. That's one of the signs of fetal alcohol syndrome, and this can lead to behavioral, physical, cognitive problems, all these kind of problems. Final one we're just looking at on drugs, because there's a lot, but we're just talking about the basic ones, is cocaine. Cocaine results in high quantities of spontaneous abortions, low birth weight, cognitive problems, and the baby can be born addicted and have withdrawal-like symptoms. Before I get any farther, you don't need to know exactly what each of these does for the exam. However, know that if I say which teratogens are drugs, you should be able to identify on a list which ones are. That type of thing. Next we'll look at is diseases. So we've got things like rubella, which is German measles, is associated with blindness, deafness, heart defects, mental retardation, which is now called various different things, but this is in exposed infants. Diabetes increases risks of premature birth, stillbirth, or miscarriages. It can lead to immature lung development and fetuses that are exceptionally large. Syphilis can cause stillbirths or miscarriages. Exposed infants, infants who are exposed to syphilis during the birth process, may have blindness, deafness, heart problems, or brain damage. That's why you're supposed to get a STD test while you're pregnant, so that they can find out if you have any of these things, so that if the fetus is exposed, they can basically treat it before that even happens. AIDS, it can be transmitted via the placenta or blood exposure during birth. That's why typically, if the mother has AIDS, they'll do a C-section to avoid that, but it can also be transferred through breastfeeding. And just because you have a C-section doesn't mean it avoids this. Next set of teratogens is the environmental ones. We're just going to talk about two of them. Radiation. So doses of radiation from X-rays and cancer treatments are capable of causing mutations, spontaneous abortions, birth defects, that type of thing. And then pollutants are all these adverse effects on the environment, air pollution, cigarette smoke, lead, mercury. If the mother is exposed to these, it can be passed on and the fetal development can be hindered as a result. Okay, so I told you I'd come back to morning sickness. So let's look at morning sickness real quick. Morning sickness is a very interesting thing. That is, women like to get rid of morning sickness. You think like, okay, what? You don't want to get sick. But evolutionarily, why would morning sickness exist? So the evolutionary pressures should select against anything that causes a deficiency in calories in a pregnant mother, because that can cause issues with the fetus. She should be trying to get all the calories she can, and evolution should favor that. So if morning sickness does occur, there has to be a reason for morning sickness to occur. And that is, what has been found is that morning sickness actually aids in fetal development. That is, when the mother takes in teratogens from the environment, she is more likely to have morning sickness. So things like food-related nausea is more common in relation to foods that contain more teratogens, like red meat. Red meat is more likely to contain bacteria. That bacteria can be passed on to the fetus. Food nausea is more likely to occur from that. In environments where there's more teratogens, like in hot, humid environments where you've got more bacteria that can grow, in those environments, morning sickness is more common. Here's the problem I go back to with prescribing medications to treat morning sickness. What has actually been found is that women who have more morning sickness actually are more likely to carry their babies to term, are less likely to have miscarriages. Women who have less morning sickness are more likely to have miscarriages, even if they're having less morning sickness because they're prescribed a medication. That is because the morning sickness is protecting the baby. If you do something to prevent the morning sickness, you're potentially harming the developing fetus. So there's a reason we have morning sickness. It might suck, but there's a reason women have morning sickness. Let's look at something real quick, just looking at how it works with younger and older women. Very young mothers tend to have higher than normal rates of birth complications, premature delivery, stillbirth. This tends to be because younger mothers don't seek out proper medical help. Their bodies aren't ready for it, first of all, and second, a lot of them don't go to the doctor like they should because maybe they don't have the resources to be able to. As far as older women, they're more likely to experience trouble getting pregnant, and they do have increased risks of miscarriages, stillbirth, and low birth weight infants, basically because of the way their bodies are, and they don't have enough of things like estrogen. The mother's psychological state. So in this case, if the mother's under severe emotional stress or anxiety during the pregnancy, they could have a fetus that has faster or more regular fetal heart rate because that's getting passed on, stunted prenatal growth, premature birth, birth complications, all due to this. Specifically for mothers who are highly stressed during pregnancy, their infants tend to be smaller, more active, more irritable, more prone to crying, may experience delays in cognitive development. Long-term outcomes are pretty similar, but short-term, there's many challenges. And long-term, there's an increased risk of developing schizophrenia. So it is one of the risk factors that has been found for schizophrenia. Schizophrenia is really hard to tell. It's mostly genetic. But one of the increased risk factors is mothers who are highly stressed during pregnancy. It could be that this high stress during pregnancy is because they have a predisposition to schizophrenia and they don't have schizophrenia, but that predisposition is resulting in them being highly stressed. It's one of those where you've got a correlation. You can't necessarily say it's a causation. Mother's nutritional intake is very important during pregnancy. Doctors recommend about 300 more calories a day once you get pregnant, and about 25 to 35 pounds of weight gain is normal. Some gain a little bit less, some gain a little bit more, but this is what is the normal average. Also, depending on when it occurs, malnutrition can result in a lot of different effects, such as stillbirth, neural tube defects. Neural tube defects are from an absence of the nutrient folate. It can result in the nutritional deficits can result in stunted growth, cognitive deficits in early infancy and childhood, and these aren't typically overcome as easily. I already mentioned this, but folate-rich gets rid of those neural tube defects. Cereal products are usually enhanced with folate, and this helps decrease the incidence of neural tube defects. It actually was a law for a while that cereals had to have this so that women could get this nutrient. Prenatal vitamins are highly recommended. This should be mandatory for women to take prenatal vitamins. Conversely, for fathers, children born to teenage fathers have increased risk of birth complications, again for the same reason as teenage birth mothers, because of lack of resources, lack of going to the doctor. Children born to older fathers have an elevated risk of congenital heart defects, neural tube defects, and kidney problems. The likelihood of Down syndrome only increases when both the father and the mother are older. If only one is older, the likelihood of Down syndrome doesn't increase. And advanced paternal age is a risk factor for schizophrenia as well. Another one of those risk factors into something we don't know enough about. Let's transition now into the perinatal environment. The perinatal environment is the environment surrounding birth. So it's the environment that basically starts when contractions start and ends at the end of birth. So one of the things to be aware of is modern day birthing practices. So medical settings tend to use technology, but make it in a home-like setting. So historically, the setting for birth was very sterile, very cold, lots of just like steel and just all of this just cold, impersonal environment. And this actually was found to be causing a lot of complications with birth because the mothers were stressed out during this time. So our modern settings are more home-like, where family members, the father, others can be in the room during the birth if that's what the mom wants. Parents want greater flexibility and control over, especially over who will control it. So the presence of supportive people is allowed in the delivery room in an environment that's much more warm and welcoming. As far as the birth itself, so childbirth happens in 3 stages. First, you get the beginning of regular uterine contractions, and stage 1 ends when the cervix is fully dilated at about 10 centimeters. Stage 2 is when the fetus's head starts to move through the cervix into the vagina and ends when the baby fully emerges. And stage 3 is the afterbirth, the expulsion of the placenta. So these 3 easy stages, right? Very easy, very simple. No complications there, right? No, it is a can be very time consuming, especially stage 1. Stage 1 can sometimes even last into days. Stage 2 tends to be relatively quick unless there's complications, and stage 3 tends to be relatively quick after stage 2. One thing we will talk about is some various different complications. We're not going to get into too detailed into the complications, but one term that's very important, and I'm sure I'll test on this, is the term anoxia. Anoxia refers to a shortage of oxygen. So this picture in the top right that you see here is when anoxia occurred. So large regions of the brain died because of lack of oxygen. When there is problems with delivery, and anoxia usually occurs due to either the baby getting stuck in the birth canal, the umbilical cord getting wrapped around the baby's neck, various different things that can cause a lack of oxygen. Assisted delivery happens when the baby won't come out, when there's complications. Things like the forceps that you see here seems very, very cruel, but it's something where the doctor can use to help pull the baby out. You've got vacuum extraction here. This is becoming more common. However, it does lead to distortions in the skull. They tend to go away relatively quickly, but because the skull isn't fully formed, it can cause some distortions there. Actually, some people still have a little bump on their head if they were vacuum extracted. And then the final one is C-section. C-section is used typically when the baby is too large, or the mother is too small, or if the fetus is out of position, things like when the placenta prematurely separates from the uterus, or when fetal monitoring reveals that a birth complication is likely. In 2007, 32% of U.S. births were by C-section. That is a very large number. Now, there's some arguments for both sides. First, C-sections may be unnecessary. Doctors encourage C-sections because of reduced liability. They're less likely to be birth complications with the C-section. It also can lead to more revenue for the doctors because they charge more for them. U.S. problems, right? Quite often people, if they've already had one C-section, they'll opt for that in future births. It actually used to be that almost all doctors wouldn't do a vaginal birth after a C-section, but now many will if you ask for it. And then the last one, which is the funny one, preference for a scheduled birth. You want to have your kid on a day that is specific, or on a time that is good for you. Now, on the other hand, C-sections are actually becoming more important, more critical, because we as humans are evolving to the point where the fetal development, fetuses are getting larger and larger. I have a friend who had her child was 9 pounds, 12 ounces, and 22 inches long. Was massive. However, she had a vaginal birth because the doctor said everything would be fine. Even when ultrasounds revealed the baby was too big and there was birth complications going on, the doctor said everything's going to be fine. They ended up having to cut her open. It's a routine thing that's done. There's a small incision that can be done to widen the birth canal that makes it easier for the fetus to come out. But for her, they had to make a large incision, and she actually couldn't even have sex for 3 years after giving birth because of that. So with her, a C-section should have been done. So there are definitely going to be cases where C-section should be done, and the number of cases where it should be done is going up because fetuses are getting larger. However, there are other times where it is unnecessary. Let's talk about oxytocin for a minute, because if we're talking about birth, we need to talk about oxytocin. Oxytocin is a neuropeptide that is released in large quantities before and after birth. It actually induces birth. Another thing is it induces lactation in women. So these are the things that it was originally designed for. However, now the body and evolution have co-opted it for some other things. Because if you know anything about oxytocin, you've probably heard it referred to by another name, and that is the love hormone. That is because it aids in attachment. It aids in maternal offspring attachment. Oxytocin that's released in large quantities before birth, it induces birth, it induces lactation, but it also leads to maternal attachment. This is why you can get women who feel that they're not going to become attached to their child while they're pregnant. They're worried about it. But then once they have the child, they become attached. It's because of this. It isn't a guarantee, but it does increase the likelihood that a mother will become attached to the infant at that time. It's also released actually in larger quantities than normal in men that are around pregnant women, which it then can do the same thing. It can increase paternal offspring attachment, but it also increases the bond between parents because they both have that oxytocin going on. And evolutionarily, this is a thing to be selected for because you want parents to stay together, especially right around the birth of a child. It increases the chance that that child is going to survive. Okay, now we're going to talk about reflexes, Apgar, look at a video of birth, not directly on from the side, and look at a video of the Apgar. So the newborn is born with certain specific responses that are triggered by specific stimuli. These are reflexes. Some of these reflexes, such as rooting and sucking, appear to have survival implications because this is where they basically turn their head towards something that touches their cheek and start sucking something put in their mouth. They will then seek out breasts and suck on them to get milk. That's survival. Other reflexes have precursors to later voluntary behavior, such as kicking. Some are not even related to later behavior. They're more due to vestigial, things that humans no longer have. And the newborn's reflexes are one of the things that are an indication of the health of the nervous system of the child, which gets us to the Apgar. The Apgar Index is a index taken at birth. It's about a minute after birth, and then 5 minutes later, you'll see it in the video, where they check heart rate, respiration, muscle tone, reflexes, and skin tone, and give each of them a score between 0 and 2. So a 10 is the best, a 0 is the worst. Most babies score in the range of 7 to 8 on the first time. Ones that are below that, there's concern. Ones that are below 5, there's a lot of concern. Okay, let's watch this video.
About to give birth, this mother is well into the second stage of labor, pushing and delivery of the baby.
Come on, lady. There you go. Keep going. Go for it. Come on, bring it up. That's it, lady. Keep going with it.
Contractions have become longer, stronger, and more frequent. This stage of labor, which lasts approximately 1 hour, is shorter than the first stage, which may take from 12 to 14 hours or longer in first pregnancies. After laboring for more than 9 hours, Lee gives birth to a healthy baby boy, Carter.
Okay, that's it, Lee. That's it, Lee.
The appearance of a newborn does not fit most people's definition of cute baby. There are many variations in normal appearance that may include a misshapen head, flat nose, swollen genitals, and acne. Most of these are temporary. Weighing in at 8 pounds and 19 inches long, bow-legged, wrinkled, red, and covered in vernix, Carter represents the typical newborn. The Apgar is used by healthcare providers to quickly assess a newborn's overall physical condition. Newborns are rated at 1 minute and 5 minutes after delivery on 5 distinct qualities: appearance, pulse, grimace, activity, and respiration. For each category, the minimum score is 0, the maximum score is 2. The baby scores for each of the 5 categories are added together to get the final Apgar score.
There we go. Hi. And with crying, it's going to pink up. So are we at a minute yet? All right, so we're at a minute. And he's got some tone here. We'll even here, hold on. All right. He's taking a good cry. And we'll check a heartbeat. His lips are starting to get pink. Hi. Yeah, you look good, don't you? Got a good pulse. He's crying really well. So at 1 minute, he had an Apgar score of 8. His tone was 1, and his color was 1. He was still a little bit blue. Otherwise, he had a good reflex. He had a good cry and a good breathing. And his heart rate was 160 beats a minute, which is a good heart rate. So we'll give him an Apgar score of 8. And you can see his tone's even getting better, and he's even getting pinker. And he's crying well, and he's got normal breathing. He's making his cries, but he's...
Like Carter, most infants who are in good health score between 7 and 10 on the Apgar. Infants scoring in the 4 to 6 range are considered to be in fair condition, but may need some special care, such as suctioning of the airways. Infants who score between 0 and 3 are typically non-responsive, limp, and pale, and in need of immediate life-saving efforts.
Okay, so we watched that video. Again, that's the most I'm going to show you for the birth, but that is the Apgar score and how they test it after birth. Now let's look at a couple different things relating to it, or relating to infants after birth. So one thing we have to talk about is low birth weight. So low birth weight infants may be born in one of two different ways to have low birth weight. One, they may be born prematurely. So they're actually of appropriate size for their gestational age. Gestational age is since conception. They're of appropriate size since conception. However, they were born too early, so they're small. The other is small for gestational age. These are infants that are at the appropriate time, but they're slightly too small for their age that they're at. We classify low birth weight as infants being born less than 5.5 pounds. Recall that friend that I had that had a 9 pound 12 ounce. So basically it was at 9.75 ounce baby. 9.75 pound baby. Very low birth weight, on the other hand, is those that are less than 2 pounds 3 ounces. babies that are born low birth weight, there isn't as much concern. There is concern, but there isn't as much concern. Very low birth weight, there is a lot of concern. So what is low birth weight associated with? Things like socioeconomic status affect birth weight. Those of lower socioeconomic status are likely to have smaller babies because they're getting improper nutrition. African American mothers are twice as likely to experience premature delivery and as a result low birth weight. Smoking can cause low birth weight, as we said before. Stress and multiple births simply because there isn't enough room in the womb for everyone. So what do they do in cases of low birth weight infants? They can do surfactant therapy. This is where the baby is pressed up against skin. This gets skin contact with kangaroo care, breastfeeding, because breastfeeding has more nutrients than bottle feeding, and massage therapy to help the body start to develop. Long-term outcomes depend upon their condition, specifically their health and neurological condition, and the quality of their postnatal environment. So early intervention programs that help parents make an enriching home environment, long-term outcomes end up being very little different, if any difference. I knew someone growing up, and she could roll up her ears, and she had to have plastic surgery on her nose as a couple times as a baby, and then as a child, and then again as a adolescent, because she was so low birth weight that cartilage didn't develop properly in those areas. But she turned out just fine because she had a good postnatal environment. So let's talk about human birth and evolution real quick, just for a second, just because I've kind of talked about this one already. But there is a coevolution going on between mothers and babies, mothers and infants. And that is that it is in the best interest of the fetus to stay in the womb as long as possible. It's protective, there's good nutrients there, everything. So it is in the fetus's best interest to stay in as long as possible. It is in the mother's best interest for the fetus to stay in as long as possible, except has to exit before it becomes too large for the fetus to get out without causing complications during birth, which can kill the mother. So there's this coevolution going on, and it's why women's hips are wider and all of that. But also, as I said before, because of so many C-sections, the evolutionary pressures that are keeping babies smaller have been reduced. So now babies are actually getting bigger too. Finally, let's look at the neonatal environment. So the neonatal environment is going to be the first few months after birth. And the ideas about parenting and infant care that we have are culturally constructed. Each culture has different views on how babies should be raised. We're going to look at a few of those. We're going to look at things like breastfeeding, maternity leave, so if the mother's there, paternity leave if the father is there, and we'll consider others. I'm not going to talk about them now, or we will talk about them actually in a little bit. Things like co-sleeping, various different things relating to the way infants are raised. Let's start with breastfeeding. So we get the question, breast or bottle? All major health organizations in the world advocate for exclusive breastfeeding for the first 6 months of life. That is because there are very large health benefits to breastfeeding. Fewer ear infections, fewer respiratory tract problems, stronger lung function, better immune functioning, better weight gain. All of these are related to actual breastfeeding and not formula or bottle feeding. There are instances where women cannot breastfeed, can only bottle feed. However, if you can, the health benefits to breastfeeding far outweigh the annoyingness or stress of having to deal with it. And there are a lot of ways now, even if you aren't around all day, like you have to go to work, things like pumps, so that the breast milk can be stored. The breast milk doesn't have to be consumed fresh, it just has to be breast milk. How about breastfeeding in public? And when I look at this picture, you have to go, and maybe some of you have seen this picture before, but you have to go, why is this okay? It's just so wrong that how was she raised? How did she come to be that she can be in a public restaurant with her flip-flops on the table? Okay, joking aside, breastfeeding is natural. There should be no prohibitions against breastfeeding. In nations where we've become hypersexualized, we've become hyper vigilant about things like seeing the breast. The breast being used for breastfeeding is not a sexual object. It should be no issue for this mother to breastfeed in a restaurant when in this restaurant it's for eating. Other people are eating here. Some people are uncomfortable doing it, and that's perfectly fine if you're uncomfortable breastfeeding in public, and that's why a lot of places give places that you can go. A lot of restaurants and stuff give places you can go. But a woman who's comfortable breastfeeding in public should have no prohibitions against it. It is not a sexualized act. However, we have come to view it as something hypersexualized. That's my 2 cents. That's my soapbox. I get on my soapbox from time to time. That's my soapbox that I'm on for right now. I'll get off from that, but just know that when it comes to breastfeeding, we've got the only prohibitions we have against it are moral prohibitions, and all of those relate to the fact that we view breasts as a sexual object. When it comes to breastfeeding, though, they are not sexual objects. How about maternity leave? Here's another controversial one and another soapbox to get up on. The U.S. is the only industrialized nation in the entire world that does not mandate paid maternity leave. There are some companies that do it. There are some states that have some mandates. But if a mother has a baby and she goes on she stays home to take care of the baby, there's a chance she might not have a job when she gets back. In actuality, the U.S. government does have a guarantee of 12 weeks after birth, but that doesn't apply to small businesses. It only applies to large businesses. So small businesses, you have a baby, you stay home for a week even, and you've lost your job. There's no protections on that. The U.S. is really, really backwards when it comes to maternity leave. There's countries out there that pay the mother for a year or 2 years her salary when she has a child. Let's get to something related to that. Actually, we'll come back to paternity leave. We'll come back to that later, or if I don't come back to it, yeah, I took that out, but we'll talk about paternity leave. Even related to that, some nations have it required that people can take paternity leave. The fathers can take time off. Some have it regulated that between the mother and father, they can take a year or 2 years of time off, still paid. So we're really backwards in the U.S. when it comes to some things, and maternity leave is one of them. All right, I'll get off that soapbox. So as far as family structure, the type of family structure has an impact on the infant development, which we will get to in the next few chapters. Things like a nuclear family where there's 2 parents, step families where there's a biological parent and a step parent, single parent families, extended families where grandparents, aunts, and uncles are there. There are big cultural and historical differences to all of these, and we will talk about these in the coming chapters. But these do impact infant development. Let's talk real quick about the baby blues. So 60% of new mothers report a relatively mild, quickly resolved state where they are tearful, moody, irritable, anxious, depressed, all of these different types of things after they've given birth. And this is usually due to the fact that while they're pregnant, there's these highs on hormones in their body. During the birth, there's even higher hormones. And then after birth, these hormones just flood out of the body. So it's like being on a high and then just being dropped. For most women, this is relatively mild, and it goes away in a matter of sometimes hours up to days. Occasionally, it might last for weeks, but it is typically gone in days. Baby blues is not to be confused with postpartum depression. So for postpartum depression, 1 in 10 new mothers, so about 10%, experience a longer lasting clinical depression than just the baby blues. The baby blues is not a clinical depression. Postpartum depression is. However, most women who get postpartum depression have a history of depression. So it isn't like the pregnancy necessarily caused it, it's they were already susceptible to depression. And additional life factors such as stress or lack of social support, such as in the case of single mothers, can increase the risk of postpartum depression. Postpartum depression does affect child development. Children of mothers with postpartum depression tend to have less secure attachment, mainly because the mother who's depressed is less likely to develop that attachment. These children are more likely to have violent behavior because of the way they're raised, and they tend to have a predisposition to later depression themselves, probably genetic there. Okay, now let's talk about the newborn states. So the newborns have 4 states that they are in. So early infancy, there's 4 states, and they're always in one of these 4 states. Alert and activity. This is where they're awake, but they're not active. Waking activity. This is where they're awake and they're active. They're doing things. They're looking at things. They're playing with things. There is crying, so where they're upset. And finally, there is sleeping. They are in these 4 basically all the time. Let's start with crying. Crying is one where there's different types of cries that infants can have. And if you are a mother or you've been around a baby that's growing up, you learn to recognize these cries. The basic cry is a cry that starts softly and builds in volume and intensity. And this is often seen when the child is hungry or slightly distressed, slightly irritated. Hungry, needs their diaper changed, but it hasn't been a long time. So this basic cry is from slight irritation and hunger. The mad cry. This is more intense and louder, and this is when they're angry for some reason. This is when they are mad because they've been in their diaper too long, they've been uncomfortable. They're mad because they're being denied what they want. They're mad because they don't want to do what's being done to them. That type of thing. And finally is the pain cry. And the pain cry starts out with a loud wail, followed by a long pause, then gasping. So the pain cry usually comes when there's actual pain. One thing that's interesting about crying, I didn't put this as a slide, but evolutionarily, babies' cries are at the middle of human hearing. So even people who have lost human hearing at the higher or lower ends of human hearing, they should still hear a baby cry because babies cry at the middle of human hearing. And it's one of those reasons why it's as irritating as it is. Let's talk about sleeping. So newborns sleep 16 to 18 hours a day. However, it is a 16 to 18 hours of 4 hours asleep, 1 hour awake, 4 hours asleep, 1 hour awake, or even less than that. So that's why the babies, and hold on, that should have shown up. Cycles of 4 hours of sleep, 1 hour awake. That's why parents of newborns tend to not get as much sleep, because that 1 hour of awake, they have trouble going back to sleep afterwards. Some of us don't suffer from that problem. I can get up for an hour in the middle of the night and fall right back to sleep, but others can't. So these interruptions that happen in the middle of the sleep, especially if you're a parent that's still working, or doing other things where you're not just taking care of the child, then this can really disrupt routine and cause tiredness in the parents. By 3 or 4 months, though, they'll usually sleep through the night. So this is 3 or 4 months. By then, you're done with this. For most, some don't. And then some babies that have colic and things like that, those types of things can cause sleeping issues too. As far as types of sleep, REM sleep, rapid eye movement, or when the baby is dreaming, this type of sleep gradually decreases from 50% of the time in newborns to about 25% of the time at age 1, and then it actually even goes down a little bit more than that as you get older. You're probably getting about an hour to 2 hours of REM sleep a night right now, depending on how much you sleep. Less if you sleep less than 7 hours. I said I'd talk about co-sleeping. So co-sleeping is the practice of sleeping in the same bed with the child. Some cultures, this is the norm. Some cultures, everyone co-sleeps with their children. It can cause complications. It can cause issues. People are worried about rolling over on the baby. People are worried about the baby as they grow older becoming dependent on the parents. People are worried about privacy, things like that. But as far as the studies that have been done, because like I said, there's some cultures where everyone does this, research shows no evidence of increased dependence of babies that grow up co-sleeping. And co-sleeping does have the advantage of avoiding elaborate sleep time rituals. And with rare exceptions, it does happen. With rare exceptions, unless the mother is a super deep sleeper, has some type of mental problem where they're a super deep sleeper, or there's drugs or alcohol involved, rolling over on the baby and causing harm to the baby isn't something that happens, with rare exceptions. I say this, but then a few years ago I taught a class where someone said that their sister rolled over on their baby and suffocated their baby. She said there was more going on than that, but she wasn't willing to talk about it. So it probably comes back to one of these other things to consider. But as far as elaborate sleep time rituals, anybody who's been around a baby, a toddler, knows that these rituals just become more and more elaborate to get them to go to bed. If you're doing co-sleeping, this avoids it. I always make the joke here about about dogs and co-sleeping. So I let one of my dogs sleep in the bed with me. I don't let them until they're old enough that I'm confident that they're not going to have accidents. So they've got to be about 6 to 8 months old before I'll let a dog sleep in the bed. They sleep in crates before that. So my 1-year-old sleeping in the bed. My 6-month-old, he's been edging towards wanting to be in the bed. I took him out to pee the other night at like 6:30 in the morning and came back in, and he jumped up in the bed and wouldn't go in his crate, so I just let him sleep there. But I think he's getting to that point where he's about ready. But as far as getting him to jump up in the bed and go to sleep, it's really easy. But getting them to go in the crate and go to sleep without them having a problem, there is complicated rituals involved. Got to pet them just right. Got to make sure that they've got the proper treats. Got to make sure that they've got this, got that. So it is something that I just jokingly can talk about how this is kind of similar with dogs, and can actually say there's some other things that are similar, like those sleep cycles. The first month you have a new puppy, from the time they're 8 to 12 weeks, typically you've got to take them out multiple times through the night, so you don't get good sleep unless you're one of those like me that can go back to sleep pretty easy. Otherwise, they make a mess in their crate, and then that leads to bad behaviors. Okay, so this should have been a pretty interesting lecture for you. We were talking about conception. We talked about the prenatal environment and the stages of that and the teratogens. We talked about the perinatal environment, specifically the environment surrounding birth, and the neonatal environment, the environment that happens in the first few months after birth. Okay, thanks. Come on back.